All right, folks, if you're watching on YouTube, we are just about to go live in front of our studio audience via Zoom. We are behind the scenes of our esteemed panel. We're just getting ready to get started, so please bear with us. Greetings, everyone. Hello, this is Eric Glazer, and welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring leaders together to not only inform you, our audience, but also unearth bright spots, successes at health plans, hospitals, and various other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. For those of you who are listening to us for the first time, I encourage you to go wherever you consume podcasts, on your tablet, on your phone, go to the app you use the most, search Bright Spots in Healthcare, click on subscribe, and you'll be able to capture every single episode we do. Usually when we do a live webinar via Zoom, it drops into our podcast feed within about 36 hours. You'll never miss an episode. We've had some incredible guests the last 2 years covering all sorts of topics tied to value-based care, population health, healthcare strategy, wealth of knowledge, tons of bright spots. So I encourage you to check out many of our past episodes. There's certainly an evergreen component to almost every episode we've recorded. If you prefer video and looking at us, you could go to our YouTube channel where every episode is there as well, or our website, sharedpurposeconnect.com. Final point, in about 45 minutes for all of you here live, we are going to send you a survey to ask for your feedback. As all of you know, listen, and attend regularly, we use you as a sounding board to pick the topics for the future and ensure that we're getting better each and every episode. We look at every single survey respondent. So please take the 2 minutes it takes to complete that survey. Most of it's multiple choice, and we will take a look at it. We appreciate your feedback in advance. And if you don't complete the survey, you'll get a lot more emails from me, and I know you don't want that. All right. I also want to say, because I am not in my regular studio, I've got a co-moderator or a backup moderator in the wings. His name is Gene Ware. He's one of our producers. He is exceptional, and he will be here just in case something happens to my connection to jump on and continue moderating so we stay on time and you get all the great information that we have planned for you today. Our topic is reducing chronic condition readmissions, and we have an exceptional group of roundtable experts to share with you insights and, of course, bright spots. As usual, we are going to bypass formal introductions in the interest of time, and we are going to post the bios in the chat. They will also be in the description of the podcast. If you're listening via podcast right now, you click on that, you'll be able to see the bios of all these exceptional experts we have in front of you today and get a sense of the great information and ideas you're about to receive. So take a look at those. Our sponsor for this episode, we can't do this without the great corporate support of organizations that are aligned with our mission of sharing bright spots and have the deep expertise around the topics we cover for all of you. One of our esteemed, relatively new esteemed partners in the Bright Spots in Healthcare family is Dina. Dina powers the future of home-based care and is a care-at-home platform and network that can activate and coordinate multiple home-based service providers. And I will give you a little bit more details about them later on in the show. But meanwhile, if you want to check them out, you could just type into your browser, Dina, D-I-N-A, care.com. That's one word, dinacare.com to check them out. All right, let's get started. Oh, Q&A module. Bottom of your screen. We are jam-packed today, but I will try to take a couple of your questions and include them in the flow of the discussion as they come up. We took a lot of your questions, folks, that you used on registration and incorporated them into our conversation today. So hopefully we'll have a lot of your questions covered. But let's start now. I'm going to start with preventative programs. And for that, I want to bring in Sarah Keenan. She's a registered nurse. She's the Chief Clinical Officer of Bluestone Physicians Partners, which is also the president of their integrated care efforts. So Sarah, welcome to Bright Spots in Healthcare. And I want to ask you about what the core components are of how Bluestone proactively prevents admissions, and then if you do get admitted, proactively prevents readmissions.
Thanks, Eric. It's a pleasure to be here. The core elements are really around a preventative chronic care model. So given the folks, Bluestone serves high-risk patients in residential care settings. We're entirely mobile. It is absolutely essential to be based on the needs of the patient, medical necessity, but what's really happening at each individual visit to proactively plan on when the follow-up is. That follow-up might be with one of our providers, physicians, APPs, or one of our care management, care coordination staff. It's not waiting until the family calls, the member calls, the patient calls. It's that proactive method. In addition, it's the proactive advanced care planning, goals of care planning, making sure that it's a longitudinal, continual care plan. The other thing that is core and becoming increasingly and happily is data, particularly the notifications, the ADT admission, transfer, and discharge notifications. This has been an absolute game changer. The ability to know when our patients are hitting an emergency department, are transferring to inpatient, are going to a SNF, going back to residential care, through work that we do on the state level, particularly in Minnesota and Florida with Audacious Inquiry, and in Wisconsin with Bamboo Health. The ability to get those on at the minute notifications allows our care management staff to immediately connect with the emergency department, connect our primary care providers with the hospitalists and the ER docs. That has been absolutely essential core element in our ability to reduce both readmissions and admissions in the first place.
I like that, and I think that'll be a recurring theme today about the combination of using technology and data combined with human beings and using both of them together to have accretive value. Ashish, let me bring you in. Ashish V. Shah, folks, is the Chief Executive Officer of Dina. Ashish, as we get into talking about readmission, reducing readmissions and the strategies that organizations are putting in place, I just want to, let's outline, like, why is it so hard? Because readmissions and reducing readmissions, we've been talking about well before even I was old enough to talk. So why is it so difficult, and why are we still talking about it?
Yeah, Eric, thanks again for the invitation. And just to build on Sarah's wonderful comments, you're right, this is not a new topic. And I think, anyone who's a healthcare practitioner doesn't want to see somebody come back if it's avoidable. And so some of the challenges that we see beyond sort of creating visibility of where someone is on their journey home is oftentimes it starts upstream when that person's in the hospital. The decision support of who needs what and for how long, that is variable today. Whether you've got someone who has complex needs and is a senior, or someone who may be underserved and has some social determinant oriented issues and needs to properly partner with resources in their community. Getting to the optimal decision of who needs to go where and for how long on that journey home is something that's not quite evidence-based and turnkey in a manner. The second part that I would just sort of add is, even if you understand that somebody perhaps needs to step down into a skilled nursing facility or needs to go home with some sort of home or community-based support, today in particular, trying to find people who are high quality, that are in the service area of the individual and that have available capacity is a growing problem. The number of organizations that are having a difficult time, even when they have the plan defined as Sarah described, but then trying to find people who can actually fulfill the promise and delivery is a challenge. The final point that I'll make is, once they are sort of on their journey back home, having visibility into how that care is progressing longitudinally is a challenge. If they're in for example, again, a skilled nursing facility or rehab center, not just that they're there, but how are they progressing against their plan? Or if they're at home with support or no support, are they progressing on the recovery? Are we seeing them likely to trend back into the hospital or ER within 30 to 60 days? So Sarah said it well, data is a really big component here, but data to drive better evidence-based decision-making on that next step, data on creating visibility in who has capacity, and then data on how are they doing when they're in a particular transition back to home. These are things that are blind spots, unfortunately, today in the market.
So I guess that tees me up nicely. Let's go from blind spots to bright spots. And so can you provide an example of how a hospital system is effectively leveraging data to create a seemingly positive chronic care readmissions prevention program?
Yeah, you want to spotlight some work that we're aware of in the Northeast, where health systems are using their post-acute and community-based partner network to not only just have a directory of who they may need to offer choice to, but really creating real-time visibility into their capacity. This was incredibly important during COVID when you're trying to determine who could actually take a COVID positive or negative patient and who had the available capacity. But even as we kind of come out of a post-pandemic operating environment, trying to understand available capacity by even payer type is a challenge for a lot of organizations. So we're seeing organizations team with their partners in their community to unlock real-time availability data to drive faster placement decisions. And then secondly, once they're in that environment, really enacting interoperability like solutions. So as Sarah mentioned, there's good solutions in the market around ADT data, but now gaining visibility into length of stay, visit notes, patient assessment data that can really surface social, behavioral, and functional needs. This is really critical. We're aware of work in the Northeast where a large reputable health plan is partnering with a large home-based provider. That daily visit is not only providing feet on the street in a patient's home, but they're surfacing really incredible data that's slowing down progression to long-term nursing home care. It's reducing avoidable ER visits in the order of 30 to 40%, as well as reducing readmissions for complex chronically ill patients in the order of about 30% as well. So really meaningful, but at the core of it is simply sharing really relevant data in an easy to use workflow manner.
I'm gonna bring in now Michelle Nelson. Michelle is the Director of Health Improvement at United Regional Health Center in Texas. Michelle, we know Texas creates some big challenges for serving Medicaid and the underserved communities. And I'd love for you to outline for our audience some of the dynamics that are unique to URHC and how you are leveraging data in partnership with local partners.
Well, trying to tag in on Ashish, we do use a lot of data. We have a CHINA, a Community Health Needs Assessment, and that consult team pulls in data from multiple resources, kind of give us a bird's eye view of what's going on in our community.
Hey, Michelle, can you repeat that assessment? Just I want to make sure it's everyone heard that.
We call it CHINA for short, but it's Community Health Needs Assessment, and it's kind of one of those things that came out of the ACA process. So that provides us with a lot of data on what is going on in our community, what the community challenges are, what's a strength, what's a weakness, is an opportunity, etc. We also utilize a lot of internal data from our Epic, and then we have Vizient as well. So we pull a lot of information, try to get a feeling of, okay, where do we need to prioritize our efforts and our interventions? And it's kind of bubbling to the top last few years. And of course, it was reconfirmed for us this year that it's typically our cardiovascular, our diabetics, and our hypertensive populations where we have the most information and the most resources, frankly, to take care of that population. We do have a high uninsured rate. We have about 18 to 22%, depending on when you look at it and what database you're looking at, as well as our Medicaid rate is also pretty significant. We did not expand Medicaid in Texas, so therefore we still have a high number of patients that are uninsured or underinsured. Because of where we're located right on the border of Oklahoma and Texas. We also are we're a community-based hospital. We have 8 or 9 rural communities that are in our service area, so we get a lot of referrals, a lot of in patients coming in from the secondary service area, from the critical access hospitals and others. So we have to create processes that not only take care of Wichita County, but how do we project them out into our secondary service area? So we are really looking at what can we do more with telehealth, remote, things like that to touch those patients more significantly and more robustly. A lot of the other challenges we have related to our uninsured and Medicaid population is the primary care alignment or access. Many of the primary care physicians, as you know, some of those Medicaid programs are not easy to keep track of if you're a private practice. And so there's not a place for us to send our Medicaid population that does not have a PCP currently. So we do struggle with that quite a bit. A lot of the patients we have identified are using ED as their primary care practice. So we do have a lot of ED bounce backs. And so we try to identify in the ED, what do we need to do to get that patient at least to some type of a safety net until we can come up with a more long range plan. Most of these patients in this category that hit our list or our services are those patients that have a lot of social determinant issues. They need a lot of education. It's hand holding. We call it hand holding, but it's navigation. We need to help these patients get to the next place and give them the tools they need to get better at self-management. The other challenge we have in our community related to our, I think, Sarah, you alluded to it as well with advanced care planning and some of the discussions and the things that need to be in place. So we have a lot of patients going to our post-acute, our SNF setting, and then they would come back to the hospital and either expire or go to hospice on their readmission, which indicated we probably shouldn't have been sending them to the SNF in the first place. We probably should have been having that hospice discussion first. So that's one of the challenges we're working with. We did reach out initially to our post-acutes to try to get them on board and engage with some readmission reduction programs pre-COVID, of course. And we were hopeful it would be, they would engage, but not so much. So we're back to the drawing board, and we're looking at it going, okay, what do we need to do to get them to kind of meet us halfway, or how do we reach out and get them to understand that we want to be in this together? And so we ramped up a mobile diagnostics trial program that can go into those post-acute care settings or the home health settings to provide mobile radiology and other procedures as down the road as we identify a need. But right now they're waiting 2.5 hours away is the nearest mobile diagnostics program. And so we're hopeful that by making this easier for them and streamlining that process, that they'll say, hey, they've done something great for us. Maybe we'll help them a little bit more in the future. More to come on that. Don't know if that'll work, but that's the goal.
Okay, so I just want to summarize. There's a lot there. I mean, obviously you guys are in a market that has exceptional challenges. So most people listening, it's probably, I'm sure everyone has their own challenges in their own markets, rural, urban, or wherever, but it can't be much harder than where you sit. You have done two things strategically as an organization. One, you're focusing on building collaborative relationships with the community and community organizations. So that's one thing that you're doing. And the second is because there's so many folks without a PCP and so many folks are using the ED as their primary care, you're also working to make sure that you have places to bring them if necessary. And even though it's been a challenge to get these post-acute care settings working collaboratively, you're still ongoing with them. And then finally, you're working on a mobile device, mobile diagnostic program. Mm-hmm. Okay, great. That's great. Go ahead.
I was just saying, keeping it all database, but whatever the data tells us where we need to focus.
Yeah.
Try to make sure it's relevant.
Data focused. I'm going to go to, so I have a couple of questions from the audience I actually want to integrate in, but first I want to bring in Troy Garland. He is also a nurse. He's the Vice President of Clinical and Quality Operations at Equality Health. And Troy, before we get into some of the questions from the audience, can you provide a real live example of how you guys are reducing readmissions?
Yeah, absolutely. Thanks. Before I get into a specific example, let me just give a quick overview on some of the things we believe strongly in. We do also believe strongly in that real-time data and are connected to health information exchanges in Arizona. It's Contexture. but we're using that data really as a foundation to connect the patient to the provider. We believe strongly that the PCP needs to be at the center of this work, and are passing that real-time data to our provider. We've layered on, we believe that patient needs to see the provider, and we're using the 7-day period, 7 days from discharge, if not sooner, as soon as possible. And have actually included a provider incentive, a substantial provider incentive, when they do see that patient and do the meaningful work. They will get an incentive as well. So we're driving some of the care in that direction. I do have a
Troy, is there any way, and I don't want to get into proprietary information, but can you give us a sense of what those incentives are by a percentage or anything like that, or am I putting you in a position?
No, depending on the relationship with the provider and large practices and number of patients, between $50 and $100 per visit.
Okay.
Becomes pretty significant.
Yeah.
So we also have a team of care specialists. So our team, who is really great at reaching out to members. We have care specialists, community health workers, nurses, social workers, chaplains, pharmacy staff. But our job is really to reach those patients using that real-time data, reach the patient and connect them to the provider. We fight through some of the things like bad phone numbers by harvesting phone numbers from multiple different sources, labs, lab, pharmacy, claims, HIE, provider, EMRs. So we're harvesting using the best phone numbers. We're also doing outreach in a combination of methods. We'll often do a digital outreach, let people know that we're going to be calling them in 30 minutes, which adds greatly into our connection rate with those patients. So getting into a specific example, we had a member, and this isn't all that infrequent, but we had a patient who was discharged from a hospital for sepsis. They had a wound which generated into sepsis, and was pretty sick during the hospitalization. We reached the patient at about a day and a half post-discharge. The patient had orders for oral antibiotics, DME, and some home health needs. When we got to that patient a day and a half after discharge, none of those things had happened. The medications weren't filled because of a prior auth issue. Patient didn't know how to fight through that. Home health somehow didn't get set up. And again, all of this stuff, this one's a little significant, but not all that infrequent for what we're seeing. The community health worker saw this and actually grabbed our nurse practitioner. Nurse practitioner did a same-day home visit, which turned out to be really valuable. In that same day, we were able to actually work through the prior auth issue, get the antibiotics into the patient, start all over with the DME and home health with new orders, get those set up, which I think without a doubt, without those interventions, that patient had no other recourse but to go into the hospital very, very quickly. The power of the home visit, I think, is huge because we also found that the spouse of this patient and significant other, a caregiver of that patient, was also really sick and had no reserves and was about to go into the hospital themselves. So we were able to actually intervene on 2 patients at the same time, which was quite cool. Following up for that, going into that model of connecting back to the PCP, the nurse practitioner called the PCP, got the appointment scheduled, and got the patient a visit with that PCP so they could resume the good work that they had been doing.
So it sounds like key was that notification of discharge, and you do that via the contexture?
Yes, in Arizona, yeah.
In Arizona. Then you've been doing, obviously I'm just trying to look at all my notes here that I wrote down. You're using the risk stratification tool out of Johns Hopkins, the ACG model. You assigned this to a care team, you outbounded the call, and then we're able to work with that individual to make sure we got the prior auth that was not there in the first place and probably saved a life or at least a readmission.
Absolutely.
Yeah, that's great. That is great. Regarding contexture, I remember when we were talking in the pre-production meeting, you had some good things to say about it as far as just the statewide HIE and alert system. Comments about it, just in general, for others out of state?
Yeah, sure. Absolutely. Contexture's been a great partner. There's always things I want more of, and certainly haven't been shy to point those out. But, you know, they've been around for a while. They've been strongly supported by the state of Arizona and the Medicaid program. And part of that support has, one of the big positives is there's really no big gaps of data. I think it's easily say every hospital, if not almost every hospital, is connected and feeding data into the system. So there's no blind spots, which creates huge value because that allows us to have one process with one data feed and allow us to connect to our patients and connect those patients to the providers.
It's great. And I know because you get to compare it to other systems when you're working in other states, and you feel like this one's probably superior to most at this point.
It's they've been a great partner, and I think the big differentiator is the fact that everyone is connected. There are no big gaps in data.
Let me for the group sort of a PSA to our roundtable here. There's a couple of good questions here. I'm not going to go through all of them. We don't have enough time, but I want, at least right now at this point in the session, but I want to bring up a couple. So I tend not to like jump balls, but so I encourage one of you to jump in, or I'll ping one of you. One question from a guest is, how can virtual care reduce chronic condition readmission? Does anyone want to take a swing at that? And reminder, you're all on mute right now.
Yeah, I'll take a swing at that one. Obviously, we all learned a lot of lessons during the pandemic around how to bring telehealth in, quickly. And what has come out of that, while our providers are back seeing patients face to face again, the ongoing use of telehealth has been in this use case. When we get a notification from family or one of the nursing staff, saying an assisted living or a group home, we're able to get in there immediately. Some of that is reassurance. I mean, there's many times where someone really does need to go into the emergency department, but so often it is the ability to just have that conversation, lay eyes virtually on the patient and say, hey, I'll be there tomorrow. So oftentimes it's not replacing the eventual face-to-face visit, but it's putting some reassurance in there, maybe ordering some labs, some x-rays, some medication, getting people through so that those folks can stay where it's best for them to be.
Eric, I just wanted to add to some of Sarah's comments there. What we also found is, virtual care, there's a lot of different different mechanisms to engage virtually. One of the things that we found is that alternate ways to engaging beyond just telephonic outreach or a scheduled telehealth encounter. So the ability to engage the patient or the family member in a push manner that starts an online conversation, and then using that data that comes back to create a just-in-time care management approach that would navigate to the right mechanism for intervention. Not unlike what Troy detected in his story, but perhaps somebody needs a nurse to intervene telephonically at that point. You coordinate that. Sometimes it may result in you need eyes on the patient, and it results in either a telehealth or virtual visit or a house call visit. So being able to create a little bit more of a continuous or connected just-in-time care management approach, we've seen virtual care technologies as a real game changer there.
Great. I want to try to keep us on schedule. Michelle, there was a quick follow-up to your answer, and I want to make sure we get that out. And then Greg won't get mad at me, guy asking the question. So he wants to know, and I think it's a great question actually, what were the tools that you use, or what are the tools used to connect providers and patients to the point of care to ensure that educational materials and care instructions are heard and then adhered to and followed?
So in the So starting in the acute care setting, when the patient's identified that's like a high risk or needs a referral to, and I'll be talking later about some of the clinics that we've set up, but we use the team, the care management team in the ED or the inpatient setting can make an actual referral. And so then that referral will go to a work list that connects that patient to a provider or a community health worker that will help navigate the patient to the right provider. We also use, for education purposes, we use zone cards a lot. We use a lot of the tools that you find in Red or Boost or some of those programs. So we kind of pulled some of the best from multiple different readmission reduction programs to create some of the education tools. The zone card is the thing I think we use the most to identify when patients are at risk for needing to get in contact with a provider or need more follow-up. So the zone cards I would recommend would be a good starting spot. We also use Epic tools that connect education materials right to the patient's discharge record, which follows the patient through every episode of care. So we can identify where they are and what they need next, et cetera.
Right. I want to now get into briefly into physician engagement and the importance of getting your clinicians on board with the challenge of managing Medicaid, Medicare, and the underserved population. So Sarah, stretch out, you're on deck. I do want to take a quick pause, seeing that we're about halfway through right now, and give everyone a little bit more information about our friends at Dina. I said I would do that earlier because I really think they're a perfect partner for this topic. So I'm so grateful that we were able to encourage them to join our family and help us with topics like this. If you've never heard of Dina, DINA, by the way, they powered the future of home-based care with its at-home platform and network. And what they do is they work with many leading healthcare systems, ACOs, and health plans to extend their reach into the home, and they help people live their very best lives. Their platform actually creates a virtual experience for the entire healthcare team so they can communicate with each other and help patients and families also stay connected, even though they may not be physically under the same roof. So Dina helps professional and family caregivers capture rich data from the home, everything we're talking about today. Then they use AI to recommend evidence-based non-medical interventions. And if your organization wants to make it safe and convenient to deliver services to consumers in the comfort of their own homes, I think it's at least it's good. I would recommend at least talking to Ashish and his team. They're really great to just hang out with. I could tell you from experience, and they're not a hard sell. So if you do want to talk to them and just pick their brain, even if you decide not to do work with them, I highly encourage you to do that. And when I send out that feedback form in about 15 minutes, you could just request an introduction. And I will not just send out an email address for someone to follow up with you. I'll actually personally make an introduction to Ashish and his team to you and be involved in that. At least for a little bit, if you want a warm introduction to that team. Thanks to the folks at Dina for being part of Bright Spots in healthcare. So Sarah, let's talk about how Bluestone is managing high risk by combining data and their clinicians and your whole approach to physician engagement.
Yeah, it's so important. Timing is everything with physician engagement and data. Sending physicians, a bunch of data on spreadsheets or something that's not connected. Hey, you're going to see this patient in a month. It's just not effective. Our providers are really busy. So the ability to organize data from multiple sources. So we're an ACO, so we've got gobs of data that are coming around utilization, organizing that, the ADT feeds, and probably most importantly, the data that's coming from our own teams, assessment data, concerns. One of our care managers are seeing people. So we've got systems in place where that data gets put together. Then we have developed a system which we call case rounds, but they're just kind of your classic IDT meeting that are held weekly. They're almost a virtual stand-up huddle in which the care management staff is organizing this data, bringing it to the care team. So saying, out of your panel of, a couple hundred folks, these are the 10 patients that have risen to this level of risk from that multiple entry points of data. And the providers also have the ability to say, I know, Bob's not on that panel today, but something's going on. So then we can deploy that and get the right person at the right time. Do they need an extra visit? Do we need to send psych in? That type of thing. But the importance of bringing that data to the providers as close to the point of service as possible. And that ranges from, prevention of readmissions and admissions through closing quality gaps, all of those type of things. It's the organization of that data. The data at the patient level is also really important to organize. Our patients, for example, have an average of 8+ chronic conditions. A large percentage also have a diagnosis of dementia. So organizing that clinical data as well in terms of risk, what we're approaching, what we're focusing on each month has also just been mission critical.
Perfect. And a perfect segue to my next question, because when we talk about patient level data, obviously, in today's day and age, 2022, we're talking a lot, not only just about clinical data, but about social determinants. So, Troy, I'd love to hear a little bit about how Equality Health is approaching social determinants, and if you have an example of how SDOH has been part of your, not only your data collection efforts, but your execution, like how do you take action on that data as well?
Yeah, absolutely. Thanks. So SDOH really is healthcare to us. Our population is 90% plus Medicaid. So there's very few of our members that don't have some kind of need. We really see SDOH needs as really that built-in reserve that is the difference between seeing your doctor for healthcare needs or using the path of least resistance, going to the hospital for those needs. And that translates really easily into the biggest driver of cost. So we have a person on our team, Annabelle Castro-Thompson, who developed a culturally based SDOH assessment. So we've validated that through research and rolled that out to our network. So our providers are using this assessment on a daily basis and gathering information around SDOH needs. Our clinical team, with every interaction, is also assessing for those needs because they change, and honestly, it's the first point of building trust with that patient. So as we identify one need, we know that it doesn't happen in isolation. If someone has a need for food, they have other needs as well. So we consistently dig in to find more, and are really happy when we can solve as many needs as we can. So as far as an example goes, really powerful. We had a patient who gave us a call and needed help scheduling an appointment for her 2 boys. She's undocumented in Texas, and her 2 young boys were in the Medicaid program. We were able to schedule an appointment, no problem, easy stuff. Found out during that she had transportation issues. She had no way to get to that appointment. So we set that up as well. Great. We checked the box. We did an SDOH intervention. Super. So we asked the next question and found out that she has no computer, no internet access. Her SSI benefits need to be renewed. Her Medicaid application needs to be renewed. And then, oh, by the way, she's 5 months late on her rent, and she's in the middle of an eviction process. Crazy stuff, right? These are the big things that happen every day in lives of our patients. So our community health worker really was a miracle worker in this case. Went to the house, got the computer set up, got the applications going, actually hooked her up with a smartphone and internet access through a community-based organization, and then called the landlord and got the landlord to stop the eviction process, waive the late fees, and then connected with another community-based organization to help with the finance to meet those past due rent payments. Pretty amazing. And the kids had some significant health issues as well. So the community health worker actually attended that appointment with the PCP to advocate for those health needs, of which there's no doubt that we were on the verge of another hospital visit, another ER visit, because it's the path of least resistance. When you have no other reserves or resources, you're going to go to the hospital. So no doubt this, along with every other scenario similar to this, proves that there is an ROI in SDOH.
That's great. I mean, it's not a great story. It's a sad story, but it's a really impressive story and how you were able to help a family in a very proactive way. That was great. Thank you for sharing that, Troy. Let's everyone put on their executive hats for a moment, and I'm going to bring in Ashish. We're going to call him Professor Shah. Ashish, like if you had a lecture hall of healthcare leaders and innovators, we'll call it, most people say, oh, you're at Harvard. I'm going to say you're at Bright Spots University, which is more esteemed than Harvard to get into. And I'd love for you to map out how everyone in the audience, all these CEOs and executives who have the CEO's ear, would approach building a best-in-class transition of care program that generates best-in-class readmission rates throughout the entire country. So I'd love everyone. Let's take our pens out and let's get at least the blueprint down here, and then I'll ask our roundtable experts if there's anything they would add to it. But let's really get a blueprint down for everyone on the call today. Go ahead.
Eric, thanks. So I think there are a couple of things here. I would break the sort of problem space into two components. How do I safely get people from the hospital back to their next step and ultimately at home? And then once they're at home, how do we keep them safe in their homes and communities, continuing down a very healthy care pathway? So sort of two components. Listen, I'm not going to share anything that many leading healthcare organizations aren't already doing in terms of investing in population health, transitions of care programs, care management innovations that are taking place. But if there was a very simple idea that I would sort of ask everyone to think about, which is how do we move from a little bit more of a top-down model where people are geographically removed and trying to engage, and think about plugging in to the homes and communities of the members and patients that you serve. So think about it as a plug-in or adapter to your existing care management or population health or transitions of care solutions that are out there. You don't need another risk stratification model, another measure to look for open care gaps based off of clinical, financial, or administrative data. But I would really think about what does it mean to plug into the home? And so if there's a blueprint, we break it down into a few different components. The first would be most people have a post-acute network that has their partners on the skilled nursing and home health side. I largely consider that post-acute 1.0. I think when I listen to a lot of the dialogue here, we need to start thinking more about post-acute 2.0 and how do we start to make more standard things like access to transportation, nutrition, durable medical equipment, courier services for meds at bedside. I know that was a question that was asked in the chat, live chat. The number of things that that could be delivered in a traditional healthcare setting are being unbundled and can be delivered on demand in patients' homes and communities. And so keeping tabs on all those partners, organizing them into a way that you can efficiently, perhaps through technology, engage them and learn more about their capabilities, but also their availability. So I think thinking beyond your traditional post-acute network and post-acute 2.0 is maybe the first thing. The second is data sharing. So directories and registries are great starts, but I think to really affect care, we're looking for a live connected ecosystem of partners to be able to collaborate and share information. So it's just not good enough, I would say, to have your partners in the community indexed. They need to have a heartbeat and you need to be able to work and communicate with them in real time. The third component is
before you go on to the next one, data sharing, live connected ecosystem. How are people going to do that high level?
Yeah, well, first it starts with, we see a lot of organizations, whether you're a health plan or a large provider group or system, they're issuing point in time RFPs to collect as much information about their partners. And the reality, very noble and a lot of effort goes into that. But the moment that document is complete, it's out of date. And there's a lot of fluidity to that information collection. So creating a continuous process to understand what your partner's capabilities are in your community, or if a new partner or service emerges, is part of the challenge. There are a number of digital tools out there and networks that people can plug into very efficiently to help them organize their existing ecosystem, but also extend it. So I think technology has a really big role here to kind of move beyond the traditional RFP model that many have adopted. There's just a couple more points here that I would share. So, beyond sort of extending your post-acute network and the data sharing, I think organizations need to also think about personalized and local outreach and communication. It needs to be simple. I know that one of the panelists mentioned zone tools. And if you're not familiar with zone tools, they're just really simple visuals that help a patient understand, ask themselves a few key questions, and based on the answers, let them know whether they're high or emergent risk or low risk. The reason why those tools, albeit in print and not a lot of data sharing occurs with them, they're really effective. And so being able to speak and communicate in simple terms with your patients and families, I think, is another key piece that has to be prioritized. Whether that's your patient portal, your text engagement programs, or any other mechanism, you need to be able to communicate in less healthcare speak and more local and patient-centered speak. I think when you have this infrastructure in place where you can partner with people in the community, you've got simple communication tools to reach patients and families, what you can activate then with this feet on the street in the homes and communities of patients and members is really just-in-time care management. And I think today, many of the panelists have touched on really wonderful stories of when they were connected, they were able to understand the situation and actually activate care that probably wasn't on the original care plan, probably not something that you could detect in a review of claims or acute EHR data in a care management function in a call center. It was really extending the reach in the home community. So the central idea here is a lot of great investments have been made to date. Nobody needs to think about throwing those out or doing anything like that. I would really think about the next step, which is take that wonderful care management, pop health, transition to care program and bring it home and really partner with the members of your community that can really help extend your reach. That's we're seeing that work in the market, really wonderful breakthrough innovations in that area. But I would say that's sort of the challenge for the industry, is to get as close to where the patient is in their home experience.
I took copious notes there, so I want to summarize it for the group if they haven't gone or grabbed it all. But as I do that, though, I want to actually, you were talking and it sparked an idea. Like, I know in preparation for this, your team had sent me a case study from Jefferson Health. It was something called like extend reach into the home. Anyway, it was a case study. It was written by Dina, so there is some promotional stuff on it, but it really outlines a lot of the key components to what Ashish just outlined. So I would highly recommend you grab it. And Sherry, if you don't mind, why don't we just throw up a poll, and if people just want a copy of that PDF, we'll send it to them so they don't have to go find it on the website or register for it. We'll just send it to them. If you want a copy of that case study from Jefferson Health, we will. I'll send it to you personally, and you can just grab it there. But I think it's a really good summation. Let me see if I could sum it. So I have 5 things that you mentioned. First of all, post-acute network 1.0 with the regular partners, still critical, still important. So I list that as 1, but then you mentioned post-acute 2.0, and that would be access to organizations and companies that are doing things like courier, transportation, DME. You referenced it as feet on the street partners, which I really like and may steal. So make sure you have feet on the street partners in place for number 2 and a process to manage those partners. Number 3, which we double clicked a bit on, was data sharing, that live connected ecosystem. Number 4 is a personalized and localized communication plan, including training, getting folks to be able to speak local. And the 5th one was just-in-time care management, I believe, is what you mentioned. And those are the key things that we would blueprint out if leading a course at Bright Spots University.
Yeah.
Rest of the group, anything else you would add to that?
I think I would add, just to highlight the intentionality and preparedness of those local connections. It's been a real game changer for Bluestone. I think a lot of people have talked about that. By nature, folks who are, polychronic, high risk are going to have a lot of people involved in their care, from formal, informal, and quasi-formal caregivers, neighbors, church. putting the time into as part of getting to know that patient, to identify those folks, to document, and then to Ashish's point, to connect them it needs to be done proactively and with intention.
And then Sherry, great point. Adding on to that is the coordination of knowledge and data so that everyone knows. Everyone's not working in a silo. They're working together, know what each other are doing for that patient.
Mm-hmm. Yeah, as an example, Troy, and you'll appreciate this as a fellow nurse, Bluestone has an internal communications. There's nothing magical about it. It's called the Bluestone Bridge, and it's a multi-directional communication platform. So, the staff at assisted livings, the family, home care, hospice, care coordinator, DME, are all on this in this ongoing communication. I call it a care conference that never ends. But it is that intentionality and the ability to say, if someone to jump in and go, oh wait, don't prescribe mom that, she had a reaction 2 years ago. So it is that ability to connect people across different areas when everyone's not employed under the same roof.
That's fantastic.
Great stuff. Great job, everyone. That was really interesting. I'm going to move off that topic a bit and talk about, bring Michelle back in to talk about another bright spot in chronic care. So, Michelle, I'd love to understand what UHRHC has done that you consider a bright spot or success, and then get an understanding if they're taking that success and expanding it or cloning it in different areas of the organization.
Yeah, so one of the things that back to identifying some of the opportunities we had around our cardiovascular heart failure patient population. So years back, it was identified we had some opportunities to better care for the heart failure population, to reduce readmissions, get them back to where they want to be in their home setting, things like that. So the heart failure clinic was born through some local cardiologists and our senior leadership team, and they said, yes, we're going to do this heart failure clinic. We do have, it's a medical director, cardiologist is a medical director, and then it's staffed with an APN and an RN. And we've since added kind of a navigation community health worker to this team to help address some of the social determinants and some of the other things that this population has. So the most of this population, however, is in that Medicare. They're the 65 plus. So we do have a higher number of insured patients. So it is a lot easier to get them the follow-up care they need. But we still have a number of them who do have some challenges around social determinants. So we do use a lot of support from the navigation of the community health worker team. A lot of education, a lot of helping the patient identify, what they need to do to self-manage, making sure they do their follow-up appointments. We make sure they can get to appointments. Can they afford their medications? Do they need help with other things? We have added Find Help. It used to be called Aunt Birth, now it's called Find Help. And as I talk about this clinic and then the clinic that we've expanded to, we depend a lot on the inpatient side and the post-acute or the discharge side on Find Help to help get these patients aligned with community resources that are providing the services that the hospital isn't. We don't want to be all things to all people, but we do understand the community has a lot to offer. We just have to leverage that, take care of this population. With this population too, back to the advanced care planning, goal setting is very important. We need to know what these patients do and don't want as they navigate to the disease trajectory. Currently, the bright spot, it's working, I think, our readmission rate is about 8.8% for the patients engaged in the heart failure clinic, as well as their ED utilization seems to be less post-engagement in that heart failure clinic. So I believe our hospital heart failure readmission rate is around 15-ish%, give or take. So we are tracking along better than the overall readmission.
That's almost 100% difference.
Yes, it is.
That's impressive.
Yes, if the patients engage and do all of the things they're supposed to do, it's not hard to keep them out of the hospital. Well, I shouldn't say it's not hard. It's very hard. It takes a lot of work, all hands on deck. But if they engage and do the things, it does help them have a better quality of life and help them stay at home more than in the hospital. Because of the success of this clinic, the secondary population we identified that caused a lot of readmissions and ED utilization was our diabetic population. So the transition clinic, which is another clinic that's very similar to the heart failure clinic, except for this population tends not to have commercial or Medicare funding as much. There's a much higher.
Hey, Michelle, I just want to summarize the heart failure clinic before we get into the cloning of it for the diabetics, or sorry, people suffering from diabetes, I think is the right way of saying it. So you have the APN or an RN, you focus on education and navigation, and then the SDOH assessment, and then all the community assistant programs to address those SDOH issues are the keys to that program working. And you went from what looks like a benchmark in the hospital, 15%. Your clinic, the heart failure clinic, is down to 8.8% for readmissions, which, I won't do the math, but you guys listening can. That's pretty significant difference. Did I capture all of that right for everyone?
I think so.
Okay, so now we're into the transition clinic. Go ahead, sorry.
So the transition clinic is the same model. We have this one, however, is staffed by a primary care provider. We did one of our family practice physicians in the community. This is his passion. And so he came on board and he staffs that clinic 4 days a week. And then we staff 2 or 3 advanced practice nurses or PAs in the clinic with him. So we have a large patient population. The population tends to be a lot of diabetics, but we see pretty much, it just grew into this clinic that sees everything. But we do have a lot of social determinant assistance that's needed for this population especially. So we use the community health workers, we use our high-risk navigators. We kind of throw all of those people into the pot to kind of identify what does this patient really need to get to a self-management level. Back to the primary care option, in order for us to get this patient to a primary care provider, they have to be less high needs. They have to be something the primary care physician can handle in a 15 or 20 minute appointment. Most of these patients are 30 to 45 minute appointments. So we start out with this high need patient and we try to get them to a self-management and to get them more accountable for their own health. We do a lot of referrals to community partners, the food pantries, transportation, housing, medications, ramp building, roof repairs, you name it, we've done it. I don't even want to, we've just done it. The other thing with this is that with the diabetic population specifically, we have seen a 77% improvement if they're in the navigation program or the transition clinic program, and they're a little bit different, but they kind of dovetail on top of each other as a 77% improvement of the patient's A1Cs overall average. The average individual improvement is 1.7 points on the A1C scale. We had one patient who, I don't know what his initial score was, but their A1C dropped 10.6 points when they were involved in this program. So we really try to focus a lot on getting their A1Cs back to a good level so that they can manage and stay out of the hospital. The transition clinic readmission rate is currently sitting at about 9.8%, and the ED utilization is also tracking is decreased after engagement with the transition clinic. We kind of look at the 6 months before and then the 6 months after to see, is the ED utilization the same, or have we impacted it at all? So we have seen some good outcomes with both of these clinics in that sense.
It's great. It's a great story, a great example of bright spots then within an organization cloning it. By this time, folks, if you haven't already, you see that survey in your inbox. So I ask you the favor, as we're here approaching the top of the hour, of providing us that feedback. That would be awesome. And you could also request to be connected with Ashish and his team for some brainstorming as well. So, and our producer, Sherry Keel, great job. He just posted the link to the survey there too, if you don't want to go to your email. We had a couple more questions for you to ask to our panel and get you guys some more information, but we're out of time. And I just think asking any one question now will force us to go over. I know a lot of us can't go over the hour. So I'm gonna cut us off now. I think it's the best move for all of us. I I want everyone to know who's listening that every time we produce a show, we know the hour you take to listen and to watch is part of a very busy, challenging day. We don't take that for granted, and we hope that each and every episode we have provided you with valuable information. To the esteemed panel, thank you so much for all the work you put in with me prior to the show and obviously executing it on today. A lot of great stuff here. So thank you very much for that. Gene, backup quarterback. I thought you could get in today, but fortunately I stayed healthy, but thank you for being there to back us up as well. I appreciate it. And to the entire team, Sherry Keels, the entire team behind this. Like I said, folks who's listening, we do this for you. And I like saying at the end of every episode, this is your Bright Spots in Healthcare podcast. Have a great day, everyone.